Jayda Hart. I am an M3 at USC School of Medicine, Greenville.
Nice to meet you,
Nice to
Jayda.
meet you.
Hi, I'm Tosin Goje, and I am a reproductive infectious disease specialist at the Cleveland Clinic in Cleveland, Ohio.
Wonderful. Perfect. So I've read your paper. I have a couple questions for you about it.
Okay.
So in your opinion, what are the most common diagnostic pitfalls providers make when evaluating vaginal discharge and irritation?
I think the first is just assuming that all itch is yeast. That's one. And that all vaginal discharge is abnormal. Those are the first pitfalls. And then we can now go down to self-diagnosis versus empiric treatment. So let's break it down. All itch is not yeast. I've seen in my 13 years as a specialist, patients get called in an antifungal because they're itchy. So I think misdiagnosis is a big thing. The other pitfall, as I explained, is the idea of abnormal discharge. Not every vaginal discharge is abnormal, so there should be a lot of education. As infectious disease specialists, antibiotic stewardship is important. You just don't want to keep exposing patients to antibiotics based on how they feel. And of course, as I said, there's misdiagnosis, self-diagnosis. So in 2025, I'll recommend that patients should be examined, plus or minus some investigations done, preferably with either the microscope or molecular testing.
What role do you believe hormonal changes, whether that's menopause, postpartum, how does that play into misdiagnosis of vulvovaginal conditions?
Oh, of course, that's a good one. Hormonal changes make a difference. So we talked about vaginal discharge. It's not every vaginal discharge that is an infection. Females have a change in their vaginal discharge based on their menstrual cycle. So it's always important to ask the patient what is the cyclical change they see with that vaginal discharge. My mentor will say that a normal vaginal discharge is like the foam on a latte. That's David Soper. He's like, it's like a foam on that latte you drink, which is different from the grayish, homogeneous, malodorous discharge of BV or the curdy, cheesy discharge you might think you see with yeast. So, in a reproductive age person, the discharge changes with your menstrual cycle. And in the postmenopausal patient, it's also important to know that atrophy, which leads to lack of vaginal estrogen, can cause symptoms. The commonest symptom is vaginal itching. When my patients who are menopausal have persistent itching despite antifungals, they need to be examined. And all they may need is just some good old vaginal hormonal therapy or even a vaginal moisturizer that is over the counter.
Okay.
So it's important to pay attention to the cyclical changes and the phase in a woman's life or a female's life.
So a good history, what I'm hearing is a good history and physical exam.
Of course, a good history and physical exam. And because I love the microscope, plus or minus.
Yes.
Yeah. And I just want to throw in, when do you think you need the microscope? So for an M3, you have this 56-year-old with persistent itch and vaginal discharge, and she's been called in antifungals and antibiotics. She comes in, we do a molecular testing that comes back negative, but she continues to say, I'm itchy, I'm still feeling not myself. It's time to look under the microscope. It could just be atrophic vaginitis, which molecular testing is not going to pick up.
Interesting, very interesting. So how do you approach recurrent or treatment-resistant cases of bacterial vaginosis or candidiasis different than like the standard protocol?
So we have to break that into two, because the treatment of recurrent candidiasis is different from recurrent BV. So let's start with recurrent candidiasis or recurrent yeast infection. We define that as having 3 documented yeast infection in a 12 calendar period. It's important we make a diagnosis. That's one. Two, you want to take a history of risk factors. Patients with uncontrolled diabetes, patients taking the biologic. Now there are a lot of biologic medications for autoimmune disorders that will suppress the immune system, just like uncontrolled yeast infection. You want to take a history of continuous antibiotic use, chronic steroid use, because sometimes you have to find a way to remove the inciting agent to make sure that the patient gets better. I have patients whose A1C is 11 or 12 with persistent yeast infection, and I send messages to their internists to say you need to control this diabetes. So you need to take a thorough history, then of course you examine the patient. At this point with recurrent yeast infection, a fungal culture is the gold standard. A fungal culture will identify the species of Candida, and if you take it to the second step, you can get sensitivities to antifungals. Because patients might develop resistance to the common antifungal you've been exposing the patient to. So those are the first step. And of course, when you now know the sensitive antifungal, you can go ahead and treat the patient. The final step is suppressive therapy. So you've treated the patient with the appropriate antifungal. You can discuss suppressive therapy with the patient, which many times is the use of like fluconazole or miconazole weekly for 6 months. There are other medications that are out there, like oteseconazole, ibrexafungerp. Depending on what you have in your locale, you can always, offer such suppressive therapy weekly to the patient. Now, for recurrent bacterial vaginosis, is a different thing. Bacterial vaginosis is syndromic. Unlike yeast, you cannot say I'm going to identify the microorganism.
Right.
It's a dysbiosis. So you also want to think about the feminine hygiene of the patient. Recurrent BV can be seen in patients that have a copper IUD. You also want to talk about the sexual activity of the patient. A lot of education and counseling is needed in the management of recurrent BV. After doing your counseling and education, and the patient continues to have recurrent BV, you have to consider biofilm as one of the reasons. We have boric acid as a disruptor. So one of the commonest combination I give is oral metronidazole for 7 days with vaginal boric acid as a disruptor for 14 to 21 days to address the biofilm. Some experts will say if you try the metronidazole by mouth with the boric acid and it's ineffective, you can switch to another class like oral clindamycin, or you could even switch to vaginal metronidazole. Now, having done that, the next step, of course, is to consider suppressive therapy. Jack Sobel has that wonderful paper. I'm sure it predates your days of using metronidazole gel as a suppressive therapy 2 times a week for 4 to 6 months. And that's the recommendation. Now, some patients might not do well or might still continue to have breakthrough symptoms. You have to consider BV at that point as a sexually associated or a sexually transmitted infection, and then bring the patient back with their partner to talk about the use of condoms for maybe 3 to 4 months in addition to retreatment, or even partner therapy as is being discussed now. But you need to bring back the partner after you've done everything and the patient continues to have breakthrough infection.
Very cool. Have there been any updates or paradigm shifts in the management of vulvovaginitis since your article's publication in
Of
2017 that you would emphasize today, if you could?
Of course. I mean, for vaginitis in general, I'm proud to say as a reproductive infectious disease person that we have made some advancement. So like for recurrent yeast infection, for example, we talked about suppressive therapy with fluconazole, but now we have oteseconazole, we have ibrexafungerp, and we can compound vaginal amphotericin B or flucytosine. So there are other options for patients who have fluconazole resistance. And of course, for bacterial vaginosis, the new kid on the block is EPT, meaning treating the male sex partner in females that have recurrent PV. Although for me, we still have a lot of unknowns when it comes to male partner therapy, but it's something that has to be mentioned. It's something that happens since I wrote my paper.
That's awesome. How do you approach balancing empirical treatment versus test-confirmed treatment, especially in time-limited or research-limited settings?
That is a big one. When I was a fellow 100 years ago in MUS in South Carolina, I think we had an algorithm whereby if a patient called and it was vaginal itching and discharge that looked like a curdy kind of cheese, the nurse practitioners could start with one dose of the fluconazole or miconazole. And then if the patient continues to complain, you actually ask the patient to come back in for an examination, because trichomoniasis can also cause vaginal itching. So that is one way to treat vaginal itching. And of course, if the patient's main complaint is malodorous, vaginal discharge, worse after sexual intercourse, especially condom-less sexual intercourse, and worse after the menstrual period or around the menstrual period, that is tilting more towards bacterial vaginosis. And depending on how comfortable you are as a practitioner, you can start with some treatment, either oral or vaginal. And if the patient, of course, does not get better, you want to examine them. I will always come back to, if they don't get better after one treatment, to get them back in for examination, because there are robust studies that show that misdiagnosis is pretty high.
Right. It's like there's something going on there.
Correct. So you don't want a patient who is misdiagnosed to continue to stay with the infection for a prolonged period of time, especially when they're reproductive age patients.
And so what considerations do you take when managing like vulvovaginal symptoms in survivors of trauma or like abuse?
Trauma-informed care is very important. That's why for every medication, you always have the oral and the vaginal alternative. Trauma-informed care is extremely important. You can shut down a patient quickly by being insensitive or not taking a thorough history. So you have to always think about trauma-informed care and allow the patient to actually direct the examination. So I sometimes tell patients, I'm going to let you direct this examination. We don't need to use a speculum. We can actually just gently insert the swab, or even sometimes I allow the patients to do it with a mirror. So trauma-informed care is very important.
Amazing. Amazing. And then my last question for you is, as trainees, we're often focused on infections, but how can we train ourselves to better recognize non-infectious causes of vulvovaginitis early in our practice?
You are so smart. So in vaginitis, I get to be called the vaginal queen actually.
I love that.
Because I do a lot of clinical work, more clinical work than research. Vaginitis is basically divided into two, infectious and non-infectious. And that's the way I approach every patient. That's why I was talking about the microscope. Because atrophic vaginitis and desquamative inflammatory vaginitis are non-infectious. And sometimes the molecular diagnostic test will not pick them up. So you must always think about vaginitis in that way, as infectious and non-infectious. And also consider separating the external genitalia or the vulva from the vagina. So when a patient has been treated multiple times and they're not feeling better, I ask them to close their eyes and tell me exactly where is this itch. Is it inside, outside, the opening? Because a patient that has contact dermatitis or lichen sclerosis or lichen simplex chronicus will have itch. And diflucan is not going to take it away. Fluconazole is not going to be helpful.
Right.
So you have to be able to put that in your algorithm of how you approach patients, especially when they're not getting better despite what you've done.
So specific localization.
That's why I said not every itch is yeast.
Not every itch is yeast. Awesome. Well, thank you for talking with me today. It was
Thank
such
you
a
for
pleasure.
having me.
You're so welcome. Thank you.